thanks for coming to this, the latest edition in our NHR supported incubator for AI and digital healthcare webinar series. For those of you who are joining us for the first time at the incubator, we convene a cross-sector community aiming to advance responsible innovation and regulatory science in AI and digital healthcare. And across that community, we get to hear about success stories and challenges across the AI life cycle. And this webinar series is a vehicle for us to kind of shine a light on those issues and open up conversations and discussions around them. And today's no difference, building on the focus we had from last month in primary care. So just to give you a little sense of the format this afternoon, before long, you'll be pleased to hear I'll stop talking. And then we'll have a presentation focusing on a story about an AI product deployment in primary care, which sounds fantastic. And we'll actually today try and make things a little bit more interactive. So we'll have a set Q&A session at the end, which we'll make sure we'll have plenty of space for. But as we go along, if you'd like to chip in with any questions, you can raise your hand. Or I can keep an eye, well, we'll keep an eye on the Q&A for you as we go along. The other thing to mention is that today's session will be recorded. Thanks very much to our speaker for letting that happen. And so we'll be sharing links with that afterwards if you want to have a look back or share things with your colleagues. So I think that's everything from a housekeeping point of view. So I can hand over. I'm really pleased today that we've got Dr. Matthew Dolman with us, who's a complex care GP in Somerset and a clinical lead for regional digital neighbourhood programme in NHSE Southwest. And we'll be hearing about the Brave AI deployment in the Southwest. So thanks very much, Dr. Dolman. I'll hand over to you and keep an eye on the Q&A and things, as I say.
Thanks, Jeff. Hi, everybody. Great to be here. As Jeff said, I'm Dr. Matthew Dolman. I'm a GP. I was a GP partner for 25 years. Left my practice just before COVID to develop a sort of a complex care GP role in an evolving primary care network. And I do that 3 days a week currently. I'm also a clinical lead in NHS England Southwest for this program that I'm going to describe now. And I do that 2 days a week. And I've done lots of system leadership roles historically, chairing clinical commissioning groups, worked in HSNs, but always been stayed true to what I hope isn't a cliche, but stayed focused on people. I'm very sort of empowered and passionate about person-centered care, and this story I hope will bring to life how machine learning has been incubated for 10 years in this story to help enable person-centered care. So Jeff's agreed to facilitate the room, and I'm more than happy to try and make this as interactive as possible, conscious that it's a little bit later on in the afternoon. So I'm going to share my screen. I've got some slides to trigger my sort of articulation of the story, but don't be fazed by the number of words on the slides. I'm just going to use them to trigger, as I say, points around this story from the Southwest. So hopefully we should be, just give me a nod, Jeff, or shout if we're.
That looks great. You're on present.
Yeah, we're good.
Perfect.
So front screen, what I'm going to describe is called the Digital Neighbourhood Programme. And in the Southwest, as a region, we've been really motivated over the last 3 years to think about place, neighbourhoods, and teams. So as a GP, I'm increasingly interested about how I can be part of a joined up multidisciplinary team. So we're building a team that includes pharmacists, hospital OTs, nurses, care coordinators. So at the outset, a couple of years ago, the region wanted to see how we could empower those teams across the Southwest with, as the title says, the best use of digital and data. So I think, again, we're going to clearly talk about how an AI product is being used to really stimulate the focus around people and bring the right person into focus for that team, for them, enable them to do personalized proactive care. So it very much is I hope, a story and an ongoing story, because we might be 10 years in, but it's as we all know, evolving very quickly. And as I say, I hope it will give some insight about how machine learning can be used really effectively. So the vision for the region was to think about how digitally enabled, data-driven, integrated teams could deliver proactive, personalized care to every citizen in the Southwest. So that's foundation of that is a regional foundation for NHS England to be the most digitally advanced system in the South region in the Southwest. So that enabled funding. So funding was found for a multi-year program, which this is, to try and unlock the tools, the teams, and significantly the learning. So we badge ourselves and hope to sort of live the fact that we're a learning program for teams, for citizens across the Southwest. And that in itself, I think, is something really important to reflect on, just as we're drawn into this conversation to learn and be connected. How do we develop that approach of being, as you say, vulnerable and curious, and safe? So I guess that underpins the regional leadership piece. The piece of machine learning I'm going to reference is called Brave AI. This is a link to their website. The story, as I alluded to at the sort of intro, actually goes back 10 years. So 10 years ago, I was involved in Somerset as the chair of the clinical commissioning group, and we were exploring outcome-based commissioning. We were looking at getting a linked data set. And 10 years ago, an NIHR program looking for a startup approach to predicting the risk of admission to hospital came into our sort of system radar. And I was actually on a panel that Bering were presenting at. And we saw the opportunity then of linking what at the time I would describe as fancy statistics, because 10 years ago I wasn't talking about artificial intelligence or machine learning, to a large data set. And basically, over the years since then, we've worked in an incremental fashion as this small startup company began to work with us in a practice to think about how the data could be visualized. And my brief to the company 10 years ago was, how do you visualize that information that's sitting in the black box in front of me, the GP data, and enable me to have a different conversation with the person in front of me? And that was the genesis of how we started thinking about using data to inform a different conversation. And I often talk about having a brave conversation. How does the visualization and the data it presents allow me as a clinician or practitioner to have a conversation with a person about their risk of going to hospital? And it's been very empowering and effective over those years. So as a region, 2 or 3 years ago, there was a decision made to invest over a multi-year period in a risk stratification tool. We went to an open procurement, and Brave was successful. And we have got the ambition and have brought that to life to work with up to 30 primary care networks across the Southwest to target over 1 million people as citizens, to enable them to work as a joined up team to deliver proactive care and personalised care. And as I say, deliver better outcomes for both the citizen, but also importantly for the team. And that, again, is a personal interest of mine, is how team members have been energized with the ability to actually deliver upstream left shifted care rather than being reactive. So that for our teams is massively important, and we believe generates better outcomes. So we've been using it in Somerset for 3 to 4 years across multiple PCNs. Some of the metrics that we've seen in my particular PCN in a care home cohort, and I can describe how we use the tool in different cohorts, has been, an impressive and significant reduction in A&E attendances, reductions in falls, reduction in callouts, and also a small reduction in primary care contacts as well in a very specific care home cohort. So, as I say, we've brought it to life and we've used it. From the actual algorithm side, it uses, and again, I'm not the machine learning scientist here, but it uses recurrent neural networks and gradient boosted trees, and it just uses primary care data. Early in the journey, 10 years ago, we looked at the linked data set, but with the information governance and actually the complexity of trying to work with that, we actually tested the hypothesis of let's just use primary care data. And of course, the richness of that data source, the fact that it's coded, has meant that the algorithm has been able to become increasingly effective at predicting a person's risk of going to hospital and also predict their potential interactions with primary care. So,
I take
yeah,
you up on your offer of interactivity.
yeah, go for it, Jeff.
Just wondering, it's amazing. You mentioned all of those different PCNs, acting together or making this available across so many different organizations. What kind of process allowed you to do that? Sharing, because usually I guess they'd be risk owners in their own right from a sort of information governance point of view.
Yeah.
And
Yeah, so the process we went through, we basically went out with an expressions of interest from the region to say, as a team as a PCN, so obviously a PCN is a collection of primary care practices. A PCN in itself isn't an entity. The data controller are the practices, but we basically went out to all PCNs in the Southwest. We managed to basically get 40 of those PCNs distributed across 7 systems interested. There's a rigorous, as you would imagine, information governance sort of checklist bundle that needs to be completed. That was all sort of founded on the work we'd done in Somerset over 4 or 5 years to ensure that the use of Brave, which is, as I say, for direct care. So the key that unlocks the use of the primary care data is the fact that it's used for direct care. We went through CAG, we went up to the national levels or Somerset. So we had that sort of IG infrastructure available to almost spoon feed the practices so that they were confident and the systems were confident that from an IG perspective, it was robust, it was safe, and we basically had everything at scale ready to deploy. The other really important element of this journey has been the digital clinical safety, which again I think is a national issue to face into about how we support teams to deliver DCB 0160. And what we've done regionally in the Southwest is produce an overarching DCB 0160 that is then able to be sort of do the heavy lifting for the primary care teams for this product, which again is being looked at nationally as a potential model to enable multiple teams at speed to facilitate spread and adoption. So there's a little bit of insight, if that answers the question.
No, that is fantastic. Well, as you've already hinted to, I think that's an amazing mechanism for spread that could be used in another kind of.
I mean, again, I think it's really, again, to facilitate this and creating this learning network. So again, we have a monthly community of practice. In Somerset, I've had a bi-monthly community of practice to enable the teams to learn together, to work together, to look at their pathways and processes, and to think about how the tool is deployed, which then just feeds the digital clinical safety perspective. It enables teams to learn together.
Fantastic.
This is a quick overview of how Brave actually looks. And I was going to do a quick demo, and I still might try and do that. The sort of flagship piece of the visualization is on that right hand element where you've got the multiple pixels in the sort of volcano pattern. So essentially, each one of those dots represents a person, and teams can hover over those dots and drag off a segment of their population, those 5 people most at risk of admission to hospital next year, from their 30, 50,000 that are represented, and you will get basically a list of those 5 to 100 people, whatever you want, next to it with an NHS number. So you can literally go from 50,000 people of a population down to 1 person and gain insights in terms of their risk of admission in 3 clicks. So again, it's a very practical, it's been designed to be practical for the team that are allowed to use it. And of course, all our teams are different skill mixes, different sizes. So it enables, again, that flexibility. If you've got a medic heavy team or a pharmacy heavy team, you can flex the cohorts that you pull out of your population to deliver direct care. So again, we've spent a lot of time working with the company to make it very effective for users, and the interface obviously is massively important in terms of getting our busy teams to use any tool at all. And yeah, again, it's the algorithm churns away in the background. So our largest PCN is 100,000 people down to, I think, 28,000 across the southwest. It provides a individual person risk of going to hospital next year from 0 to 100. It will also predict their primary care activity. So for primary care teams, it's got that potential to predict future work. Put the two together, and you can start identifying people that you don't know. And again, just a powerful story from a few weeks ago. 82-year-old that hadn't been seen by the practice for 9 months was flagged by the tool as being high risk. The carers who were looking after her weren't aware, but as soon as I walked into her room, this lady was dying. She had significant heart failure, and almost certainly this lady would not have been seen by anybody until, as I say, the data allowed us and machine learning lifted her out. I was able to put in an anticipatory care package, and she died peacefully with her family at home. And that, to me, is one of those qualitative stories that makes my job incredibly satisfying and incredibly powerful for the family and the person. And as I say, the data was actually picking up non-data, if that makes sense. So the absence of the fact that she'd been reviewed or seen was triggering the algorithm to bring her to the surface. So it's, as I say, it's proving to be incredibly important for our teams to start actually working differently. What's been important, this is quite a busy slide, but it picks up the key elements here. There's something so much about leadership, sponsorship, multi-year support, rather than sort of snippets of funding or short-term funding. We've developed a memorandum of understanding so that we can work with both systems and primary care networks in those systems to try and work together. And those 3 pillars that I've kind of touched on, making sure the information governance and the digital clinical safety is absolutely robust and safe, and to do as much of the heavy lifting as possible at scale. And we've done that. It's taken an awful long time, probably 18 months. It slowed us down massively to get that right, but we're confident we've done that. And we're still constantly learning and testing how different data culture in primary care is impacting on the model. It will work on all of the primary care EHR suppliers. It can work with hybrids of that. But again, we've had to work with the visualization in those sort of hybrid scenarios. So different PCNs sometimes have a different economy of electronic health record, but it's able to work with that. And we've definitely try to use a human-centered design approach, trying to make sure that teams are supported in the thinking about themselves and the citizen, and as I say, making sure that the technology is there for them, and how to refine that and keep iterating. And as I've said, keep a community of practice approach to learn. And evaluation, we're going to have an external evaluator. We've gone out again to a national procurement approach as we speak. So we'll be able to launch that probably in the next couple of months across the sites. And again, that's going to be really exciting to actually try and do this at scale, assessment of the impacts and benefits that we've had. Probably covered most of this in terms of we've got the funding until 2026, and we've been running for 2 years already. So the region have been ambitious and positive in trying to support this. So again, I'll pause there for the room. There's a few more slides with a bit more detail about the technical side. But again, Jeff, if there's any questions in the room or anyone wants to come on that.
Yeah, it's been fantastic. Thank you. So far, there's one Q&A just asking about some of those bundles you pointed to. Are they things you might be able to share across community or not?
Yeah, well, again, I think absolutely. We've got definitely sort of, as you say, high-level documents and descriptors of those pillars from the IG and digital clinical safety. So yes, we can do that. That's fine, for sure.
Brilliant. Thanks.
So again, so I guess this slide just prompts me again. The tool is a Class 1 medical device. So again, that's been important on the journey to give our teams and systems the confidence that the tool we're using is, as I say, going through rigorous assessment and support at a national level, international level. And I think this slide is obviously what we probably all recognise. We can obviously talk about the Wild West in the Southwest because we are in the West, but I think it's just the reality, isn't it? It's an incredibly fast-moving environment. Safety is so important, as we know from international policy. Only in Paris this week, it's difficult to really comprehend how quickly and how do we support our teams and citizens to be safe. And I think, the MRHA are obviously taking their part in that, and certainly this product has gone down that route to give it the rigor and additional assurance for people, is, I guess, my summary of that slide. Again, this was a slide that we use sometimes just with some of the teams, just to show how some sense of how the neural networks work to try and come up with its predictive elements. And the predictive value, it runs at a sort of an OROC score of between 0.7, 0.8 and 0.9, which again is evolving and fluxing depending on the data sources. But as I say, we've done prospective and retrospective reviews, or the company have, to, as I say, give us this sense of accuracy. And again, their figure I have is between 8 and 9 out of 10 admissions correctly identified. This shows those figures in terms of my PCN when we did the work. We used the Bayesian statistical model just to predict what would have happened potentially, and then what we actually saw. And that was a year before and a year afterwards. So we were running for 2 years to collect that data in a cohort of 800 people in care homes. And we used the tool to stratify and target our care at those most vulnerable. Which again, obviously, so much of our care is reactive and driven by referral or family. The ability to actually find people and have conversations with people who essentially are off radar is incredibly empowering for everyone involved. And as I say, we have a BRAVE score that predicts your risk of going to hospital, but also this demand score. So again, the ability for teams to understand those people that are predicted to engage with them is so important when teams are so stretched. we can start thinking about how to redefine our pathways and call these people in and handle them completely differently. And we also have a complexity score, which it says on the slide, you can get a sense of how much of an outlier that person is. So you can cut your population for direct care in less complex people being seen by less skilled practitioners, maybe health coaches. The most complex would potentially be seen by me, and the clinical teams. But again, it can be defined by the team that are there to use it.
You don't mind just jumping in? I've been a bit slow on the
Yep.
draw, monitoring hands. I can see Anna L's just put a hand up. I'm just going to unmute you, Anna, if that's okay. Sorry, I didn't spot that earlier.
Hi, can you hear me now?
Hi, Anna.
Yeah, we
Hi,
can hear you.
hello.
Thank you.
Hi, lovely to meet you all, Matt. So my question is, so I'm just literally a GP registrar with interest in AI and health tech. So, I mean, hearing half of what you speak, and I'm just wondering what on earth is that? A lot of it is obviously a big learning curve. My question to you is, so how can a clinician like myself, or many of us out there with keen interest, without any sort of technical background, best develop the skills that needs to be to engage in AI implementation? Is this like a quick? I don't know if you're involved in like training, or you've seen trainee doctors in your practice, and is there something that we can sort of take or a module we can do?
Yeah, you broke up a little bit in the question, Anna, but I think I heard how to support practitioners to work with AI and to work. Was that the gist of the question, Jeff? I did break up.
It's yes, just how do you so for people like myself without much technical background, how do
Yeah.
you sort of develop best develop?
So I'm probably very similar to you, Anna, just a bit older. I don't have that much technical knowledge, and I guess that's the thrust of the story, really. We've got to find ways to have practitioners, GPs, any practitioners curious and confident around using AI and machine learning, so that we can work confidently together as teams, but also obviously impart that confidence to the citizen and to the patient. And I think that swings back round to, for me, digital clinical safety. There is a huge need nationally to support and create time for teams to think about the safety of their pathways and their digital safety of their pathways. And by creating that space and time, it will enable us to use machine learning and AI safely and effectively. So I guess if you haven't looked at a digital clinical safety online training, there's a couple of hour sessions on the national websites. There's some really good resource there to give you as a practicing practitioner the questions and curiosity and confidence to ask around digital tools.
Fantastic. Thank you. Yes, yeah, that's a starting point. Thank you so much.
Yeah. So probably slide-wise, I've probably exhausted them, Jeff. So I guess it's
Yeah, well, thanks ever so much. That was a really great rundown and a fascinating story, as you say. One thing that I was wondering about is how the kind of IP share between NHS sites and Bering shook out. And it sounded like that you were with them on quite a long stretch of the journey. And I mean, obviously, the NHS sites have had a lot of value from the
Yes.
improvement to the service, but I just wondered if.
So that's covered in the contractual arrangement that we signed with them. So there's a quid pro quo in that IP arrangement going forward that was negotiated with the company. I have no personal part in that, but NHS England Southwest absolutely faced into that. And it's, again, I would probably best describe it as mutually beneficial for the NHS and for this particular company. But of course, it's a reality, isn't it? The opportunity to work with NHS data is a massive opportunity / privilege. But again, that is covered in the contractual arrangements.
Oh, that sounds great. And it sounded like as well as an adaptive model, is that right? So it's continuing to learn whilst it's deployed.
Yes. Yeah, absolutely. So again, that's what we've found, as it's literally grown from one practice of 8,000 up to a population of 300 in Somerset. It's now got nearly 1 million people from across the region. So yes, I guess that little visualization of the swirling network is what's happening. It's refining itself. And again, what's interesting is that OROC score, it changes with the obviously localization of the data culture. It can compensate for data variation, which obviously is just the reality across any primary care environment. But the fact that it's got now big data and it's done its learning, it can compensate for, as I say, this variation between practices, which is again just a practical, pragmatic, obvious question. One practice down the road will say code differently to you, but as I say, it's able to work through that. And as I say, it's unlocked that whole awareness for many of these practices around data process, data templating, how to standardize, and again, potentially unsettling for primary care, but we're absolutely trying to do it in a supported learning approach, which of course is really important.
Yeah, well, I'm very successfully by the looks of the size of the community plugged in. Just whilst others have questions brewing, I don't want to hog the conversation too much, but I wondered if there's any plans to scale beyond the Southwest, because it seems enormously successful.
Yeah, so national teams are interested. We were shortlisted for an HSJ award last year, so I know there are other parts of the country. I presented at the British Geriatric Society the other month. Some colleagues in London were interested. So yeah, I think, again, I don't know what the latest is from the company, but I think, again, any opportunity we have to support teams, and I guess then my professional interest is really around the teaming. How do we develop the reality of joined up teams? And my perspective on that is we've got to put the right person or family in front of them. And as soon as you do that, actually the teams almost, they self-motivate around that. So rather than being reactive, if we can be proactive, we can use this approach using machine learning, then it, as I say, it empowers those teams. So that's the benefit for us as practitioners.
And thinking about the shared, you mentioned the learning journey you've been on across it.
Yeah.
Are there sort of implementation settings or sites that have posed more challenges than others?
Yeah, absolutely. I mean, it's been painful. I mean, it's been 10 years of trying to find the time, the resourcing, the consistency of the team. As we know, trying to do this on the ground in a busy environment of, complex care with a pandemic in the middle, it's incredibly difficult. And, being connected into networks, without sounding, like this, we need to be able to be plug in. And like Anna said, we need practitioners to be able to get confidence and to be curious and to be in a network of learning, and share that knowledge, share the frustrations, find the psychological safety to be vulnerable and say this. But, absolutely, we've got a fantastic digital clinical safety infrastructure that could be used anywhere at scale in the Midlands, in the Northeast, across London. The national team have seen it, they're interested, but that can make it is a game changer for deploying safely. Likewise with the IG, we've got to bust the myths and allow teams to use data safely. So yeah, lots of learning, and happy to share, I'm sure, from our Southwest corner.
That's great. And do you have, with that kind of fertile ground you've built and community, are there any other kind of tools or use cases you have your eye on in this space? Or
I guess yes. I mean, just the third part of the program. So the program in the South has had 3 elements. So it was, first of all, finding a stratification tool for direct care. then to support the teaming. And then the third element was then the sort of overlay of any other digital technology to enable those teams to flourish and thrive. So, well, for instance, I'm working on a virtual ward, but a community PCN virtual ward. So we risk stratify a cohort of heart failure patients using Brave. And I've got, well, at the moment, 30 people on a virtual ward. So that, again, my team can be using technology in a smarter way to actually prevent, hopefully, as I say, deterioration, generate better outcomes. I think the opportunity, once you've got manageable numbers of people with stratification and segments, is limitless. Well, it's limited by the budget and by the ambition of the systems. But again, that's what national policy is professing to offer us, isn't it? That whole shift from analog to digital, we need to see that translate into system money for investment.
Yeah, I think it sounds like a really versatile system. I've got a couple of questions coming in, so I'm just going to unmute Paul, if that's okay, just to hand over to you. Sometimes it takes a couple of seconds, but I think.
Okay, is that done it?
Yeah, we can hear you. Thanks, Paul.
Excellent. I think Matthew touched on it a bit there, but my question was really, you showed Brave looking at risk of hospital admission. I just wondered if you'd also use that same approach to look at other risk factors, so deterioration and maybe some more upstream prevention, likelihood of non-attendance appointments and those kind of things. So you touched on it a bit with heart failure virtual ward, but if they're at the virtual ward level, they're still quite a poorly person.
Yeah. So again, a number of things. So I've always been, from a virtual ward perspective, I've always been violent disagreement with the national approach to have poorly people on a virtual ward at home. We need to be upstream. So the concept for me is to use the stratification to actually start supporting those people when they're not in crisis. And then if they do deteriorate, they could then potentially go into an acute virtual ward. That's a little bit of a sideline of frustration. But you mentioned the other visualization we have within Brave is deterioration. So it will show the change in Brave score over the last month. So you can essentially see deterioration. So you can see those people who are seeing a shift in their risk of going to hospital, which was how I actually identified that frail 82-year-old. She came into view because her score had changed with the tool. And it hasn't been trained on any other outcomes, but of course, that's the opportunity for any of the machine learning. You can determine your outcome and define it and point it in lots of directions, provided that the IG and the care is direct in our case.
It still has that challenge of scale, though, doesn't it? Because if you've got an intervention which is provided by a clinical team, that does limit down your scale and also increases the complexity, really, of the patient that you need to justify that level of resource. So it would move you to a different paradigm.
Yeah, I see where you're coming from. You're right. Yes.
Yeah.
Thanks very much. And then we've got one more question from Lingyi Wang, who I'm just bringing in. It's working now.
Oh, hi. Sorry, it's probably a broader question. Just as a student entrepreneur that applying to develop a social prescribing model for the Southeast, like how can I make the first step and then reach out to NXS to require for the data that is very essential for like establishing the model in the first place?
Well, yes. Let me try and think that one through for an answer. I think for any small or any company, isn't it? The critical thing for me would be to ensure that the product actually tunes in onto the person, and that the benefits approach that is articulated is really credible for the teams, because then that can unlock the opportunity within the, as you say, within the landscape, within the health and care environment. But it is, again, incredibly challenging, isn't it, to break into that? And as I say, my experience was, and again, maybe that is part of the learning, is to come through some of those academic NHR opportunities that are nationally sort of pitched to try and draw small entrepreneurial opportunity and bring it to life. So I guess looking out for those opportunities would be some advice.
Thank you so much. Are you referring to like incubator across NHS and potentially in Southwest, like Southeast, I mean?
Potentially, I guess, yes. I mean, again, I think it's important to be national, isn't it? The opportunity here is national, and to be open to that and be prepared to work wherever that opportunity might bubble up as I say, a regional opportunity or a system opportunity.
Thank you. That's very helpful.
Thank you, Lingy.
Thanks very much. That's great. Just seeing, we've got some things in the Q&A just to follow up with afterwards, which we can share on. But I think we may be moving towards the end of the session. So thanks ever so much for sharing that story with us. It's an amazing journey you've been on.
Well, it's a pleasure, and happy to follow up in more specifics and resources, and again, happy to follow up offline as well and connecting with the team. So we've got as I say, a regional team of IG, digital clinical safety, clinical project managers that I'm sure would be welcome, to be part of this sort of learning chance, and equally connect into the teams as well. We've got a futures site on NHS. NHS Futures, which again would be open to any NHS colleagues. And again, there's the wealth of resource there, templates, outcomes, so we can share that.
That's great. So is the group what's the title of the group roughly?
It's the Digital Neighbourhood Programme Southwest on Futures. I can send the link, as I say, and again, we'll obviously we're open to anybody. It's just
sounds like a good way for people looking to have sight of those bundles and things.
Yes, we can do that.
Sharing that. Brilliant. Well, just coming to a close, I'll just put a bit of a reminder as well for our session next time on the 10th of March. We've got Charlie Stevens, who's head of commercial for MedTech Transformation at the Transformation Directorate, in NHSE, who will be speaking to us a bit about the principles and practicalities of procurement in digital tools. So that's next month, and we'll get all that out in email in due course. But just to thank you once again, Matthew, for joining us and sharing that story. That's been fantastic, and to everybody for dialing in as well. So thank you very much.
Thank you, Jeff. Cheers. Thank you.
Bye.
Bye now.